year, the superintendents in New York State are surveyed. And the question, one of the questions on that survey is, if you had money above and beyond what it would take to just sustain the regular program, what would you spend that money on? In 2012, mental health was not even on the radar. Not a single superintendent in the state mentioned mental health. Somewhere after that, 2013, it went up to about 15%, then we saw 22%. 3 years ago, we saw 52% of superintendents stating that mental health was top priority. The year after that, it was 56. And we thought, okay, it looks like it's plateauing a little bit. You know, this past year, 67% of superintendents in the entire state said that mental health was the top priority, funding priority. That's extraordinary. You know, so the work that I've been doing with some of my colleagues has been just that, looking at, and one of the things that we've done is I've looked at national data, I've looked at state data, and I've looked at more local data, and it all paints the exact same picture. And I mean that sincerely, because I've done a lateral read across every single resource I can find, and what I've discovered is, yes, you know what, that 1 in 5 school-age children may have a mental health disorder, absolutely true. That 80% of kids develop, well, 80% of chronic mental health conditions start before they do, in the school age, in the children age. 50% definitely by age 14. So it is remarkable, and when I hear Sheriff Toulon talk about the wonderful things he's doing to correlate those things and work with schools, those are the kind of partnerships that we really do need. You know, drilling into local data. Southampton Town, my former district is in Southampton Town, so I have access to that data. The Southampton Town TAP survey surveys 8th, 10th, and 12th grades, so it's an N of about over 2,000. And they ask questions like, you know, if you felt nervous or stressed in the last month. 88% of those kids say that. 88%. 80% or 79% say that their anxiety is affecting their schoolwork. 65% say their social life. You know, social media, when you look at the correlations between social media use and then, or you see a reverse correlation between social media use and in-person social interaction. Back in 2013, there was much more back in 2007, there was much more in-person social interaction amongst our kids. I mean, I can tell you, I'm a father of 4 girls, from 20 down to 10. When I tell the stories, and I have a number of stories I share, I call myself a survivor, number one, but then when we talk about it, you know, my oldest was a very high achieving kid. She was committed to go to West Point, and she was a very together child. And I looked at her and I said, oh my gosh, I'm so impressed, I'm so proud, Emily. But Ellie's falling apart. She's in 10th grade. I can't even get her to walk into the school. Mm-hmm. And my daughter looked at me and said, Dad, you just didn't see it. I cried in the shower. And so I know firsthand what that looks like when we talk about anxiety and depression. And you know, when we look at the screen time, there is that reverse correlation. The increase in screen time and the decrease in in-person social interaction is having deleterious effects on our kids. Right. They're comparing themselves to these perfect profiles of other kids, and they just can't simply add up. So it's hurting their self-esteem, and it's hurting their self-image. You know, so as superintendents, what we look at is we try to look at that in data practice and what can we do. The school shootings. My nephew was in Parkland, okay, and when I got that family group text that said that Brandon was hiding under the auditorium seats, I wanted to see my daughters. And I met up with my daughters, but the problem was my daughters were connected to him on social media. And so they witnessed firsthand some of those kids walking out and videotaping themselves walking out over their bodies. So my reaction was, let me go into school and let me have conversations about what that residual damage is across the entire country. Because it really is, it's tremendous the impact that can have, and be. And I saw it in my own family. But you know, every in-person social interaction, every in-person, you know, whether it's sports, religious activities, increases happiness in kids. Every screen time activity decreases happiness in kids. And that bears out in the data no matter where you look, across all demographics, all SES, you know, race, ethnicity, it doesn't matter. And we're seeing these kinds of problems in our schools. And I mean, I know I'm running out of time. This is probably an hour and a half presentation on this and what we're seeing in our schools. But clearly, taking, at the earliest ages, teaching kids about resiliency, teaching kids about what it feels like when you get that bellyache. You might not be sick. It might just be that anxiety challenges as a 5-year-old. And what does that bubbling feeling feel like? Well, okay, now I know I can put a name on it. I'm anxious, I'm nervous. And now let me teach you some self-regulatory skills to deal with your nervousness. And then work on social interactions and social awareness. And then get into that last part about making responsible choices. Because that's the framework we need for. And this idea of being accepting of all and understanding those individual differences. We're doing things in our schools where we're doing universal screening for social and emotional instability. And we're looking at that data and we're saying that, no, teacher, the 5 rules on your wall in the back, that doesn't amount to a whole lot when you don't know what's in their backpacks. And you better know what's in their backpacks, because if they're internalizing, if they're externalizing, or they have maladaptive skills, there's a reason for that. And you need to treat them differently if you're going to be effective in the classroom. Because the first thing you need to understand is that kids who are experiencing anxiety, they can't learn because they're not ready. Thank you.
To the superintendent's point, this is a kickoff, so there will be many opportunities for you to speak for an hour and a half. To Mike Stoltz, what are the gaps for families on Long Island when it comes to navigating the healthcare system? Is there a dearth of services for any specific age group? And what innovative system reform is taking place in other states that would result in better access to care?
Well, I'm not going to start off by answering your question. So just as a quick introduction, my organization, Association for Mental Health and Wellness, is the Mental Health Association for Suffolk. We are one of 26 MHAs around New York State. Every county is covered. In Nassau County, Jeff McQueen, who I don't think is here today, is the Executive Director of MHA Nassau. We also come under the Mahaney's Mental Health Association in New York State, which is responsible for the Mental Health and Education Act, which is working with the Assemblywoman and the Senator on advancing a lot of the legislation at a state level. And nationally, we're under the umbrella called Mental Health America. So the reach of our organization is to be able to look locally, regionally, New York statewide, and across the country. I've been in community mental health now for over 40 years. I used to do a lot of presentations that would say, hey, what's the most common mental health condition? And everybody would say, I guess it's depression. So the last 15 years, and now do some training called Mental Health First Aid, which I'll talk about in a moment, that has shifted, and now it is talking more about the experience of anxiety. And why? We live in stressful times. For everybody here, how many people feel anxiety when you watch the news and you hear about today's climate change issues, contentious leadership nationally and locally, aggressive media, aggressive social media, some of the threats of war in the world, things that come up really quickly. These are stressful times that we all feel. And if you are a parent, a family member, or a community leader, our kids feel our stress. Right? It doesn't follow. That's just what happens. It's just like any clinicians in the room when you're working with the kids and you find out kids are feeling frightened about their parents having their distress, and then you have to go work with the parents to be able to, what's happening that your kids are feeling all this stress. Kids are a subject and responding to all the stress that's around us. So I used to do, historically, and I'm going to get to an optimistic note about kind of what's happening locally and regionally and such. Historically, I used to do lots of presentations where we would talk about, mental illness in the darkness, the stigma, the stuff that nobody ever knows anything about. There were movies called Out of Darkness, In the Shadows, Myths and Misconceptions, things like that, all about mysteries of mental illness and stuff. Let me give a little clinical, by my clinical hat, and let's kind of distinguish between two things. There's things called exogenous mental health conditions, and there's endogenous, right? Exogenous means all those things that we just talked about, that we talked about as far as stresses outside of us can cause anxiety and depression. Endogenous means there's things that come from our biochemical kinds of systems, and we would hear things about diseases of the brain or mental illnesses. So schizophrenia and bipolar disorder and psychosis, guess what? They're not on the rise. They occur the same here as they do in every other country, virtually the same by race, by religion, by whatever. What's different is how a culture and as a society responds to it. The consequences of having serious mental illness are very, very different, which is why the sheriff talks about the disproportionate number of people who wind up in our jails, because there was not a community mental health response to people having serious mental illnesses. So to go to Rebecca's question, here's been the biggest change, and I'm excited about it over the past few years, which is people now talk about their mental health conditions. We have now a change in our workforce where people who are in recovery become the experts. So if you now experience cancer, you experience cardiovascular respiratory diseases, what do? Just like you're looking for a restaurant on Yelp, you go online and you find good information. And there's a ton of it out there. What do I deal with when I'm feeling with anxiety? What do I do when my kid is feeling anxiety, depression? Where do I turn? And guess what? There are voices like never before of people who have gone through really hard and awful stuff. From the voices from the sexual abuse that happened from the kids from the physician in University of Michigan, the kids from Parkland, people who have experienced trauma post 9/11, people who experience traumatic events. So to educate and to hear. So the first line of defense as a community member is to make sure that those voices and that information is out there. And that can happen on a community level. So the change in our workforce is to have more people in our workforce who have lived experience with these conditions. We're doing we're part of a national effort, an international effort around mental health first aid. So when you came in was a brochure that talks about how many people in this room are certified mental health first aiders. Well, there's your homework. There's 3 agencies on Long Island that have federal grants that are trying to get as many people trained in how to recognize some of the simple signs and symptoms of what to do. The sheriff has embraced it. I think next week we're training the 3rd class of recruits, of correction officers, on how to recognize mental health distress. 5 steps to do that. And I'll talk about some other projects there, but these are local things. These are things that do nationally that be able to help change our communities and groups that are affected.
Great. Dr. Isma Chaudhry, the Centers for Disease Control and Prevention, recognize depression as a critical public health issue. Depression is a leading cause of both injury and disease for people across New York. By 2020, the CDC estimates depression will be the 2nd most common cause of disability in the world, following only heart disease. We have seen the impact of depression on Long Island's youngest students in this last year, expressed through suicide, violence, and sometimes more simply, not being able to participate academically, socially, and in other measures of thriving. What role do public health advocates play in meeting the needs of our youngest people struggling with mental illness, and how is HWCLI educating systems changers?
Thank you, Rebecca, and thank you so much for giving me an extra half an hour. And for the young lady in the back who's going to show me the sign, I just want you to know I'm not wearing my glasses. So a very pertinent question. What are we doing? First of all, it's heartwarming to see so many stakeholders from different agencies, representations under this roof sharing the same concern. It's extremely important that we do not get separated in our mission to combat mental health illnesses, especially in the youth. As academics, we need to understand that it's extremely important to understand the relevance of all the stakeholders. As policymakers, we have to understand the relevance of stakeholders, and then as understand the gaps which are very obvious in mental health treatments, and the gaps where the implementation gaps and the evaluation gaps. We are creating policies, and then the follow-up and the gaps are not identified in mental health. So as academics, we have to think on how to address those issues. We have to really understand the impact of mental health in the youth. Recently, I have to just digress for a second, that recently Nassau County had passed a legislation where there are signs and posters addressing Juuling. And when was the last time? So I have an 18-year-old and a 20-year-old, and you see so many young. When was the last time you saw any young adult, teenager, looking up their social media? Again, we have to understand what we are doing and who we are making relevant, who we are addressing. Nobody looks up at the signs. I don't even remember when was the last time I looked up. You take a family trip with your kids, you keep telling them, look how beautiful the scenery is, and they're talking to their friends. They're not looking at scenery, let alone signs which has a narrative and something else to read. They're not. They're done with the reading from 9 o'clock to 3 o'clock in the schools. So we have to understand who we are addressing, who are, and understand the needs of our youth, and making them relevant and part of our narrative. That's one thing that I think as an academic we are missing. The other thing is we have to align the narratives to build public understanding, and public will to understand the stigmas and the associated challenges with the stigmas. How we are addressing the vulnerable communities, how we are addressing the underserved communities and communities' needs, and how we are following up on the services that are provided. The other, as a public health advocate, we need to identify and shift the resources and the infrastructure, and the way our systems are working, and how they are processing, and how they are structured, and what are the narratives they are structured around. Again, an extremely important thing, and what comes into play in this as well is to make it successful, we have to identify the stakeholders and make sure that those stakeholders have a relevant voice in the process. The other thing which is extremely important for us to understand is to provide access and understanding and a literacy campaign around the providers and the communities. We're not addressing that. So we are putting in our resources in a pot without really understanding the relevant information. Thank you so much. I think my ophthalmologist is going to be very happy. So thank you so much, and we can move on to this discussion later.
Dr. Jeff Reynolds, what is the state of addiction services on Long Island? What's working, what's not, and what needs to be done to meet the needs?
Thanks, Rebecca, and thanks for putting together a great panel. Everyone's made significant contributions as we talk about kids and mental health, so I'd like to be here. For the sake of this discussion, FCA provides a variety of services, but most germane here is the fact that we run 2 outpatient clinics in Hicksville and Hempstead. We also run Long Island's only 2 recovery centers in Hauppauge and Westbury, and then a children's mental health program, which used to be called HCBS and now looks very different, but that could be a conversation for another day. I heard the chuckle, so some of you get it. The state of addiction services, we got really good news at the beginning of this year, and the good news was that the overdose fatality rate here on Long Island had dropped. And Newsday ran a front page story, and there was dancing in the streets, and everybody was thrilled. There was a part of me that wanted to celebrate that small gain, and keep in mind the gain was less than 10%, because every family that will now spend the holidays with a loved one is certainly a step in the right direction, but we also understand that there are hundreds of families here on Long Island that are enduring multiple holidays without their kids for something that is treatable and preventable. We also know that as we talked about the drop in overdose fatalities, we're seeing a commensurate increase in the use of benzos, in cocaine, in methamphetamine, and stuff we weren't seeing before among young people. And all of us sit around tables and talk about how many of those overdose fatalities actually moved into the suicide column, and are we counting things the right way? And so while we all pat ourselves on the back for making some gains in addressing opioids, it almost feels like we're losing ground in other areas. And quite frankly, we wind up chasing the drug of the day rather than the root causes. There was a day, I guess, early summer, where within a short amount of time, I went to the opening of the brand new DASH Center that Family Service League opened in Hop 24/7 crisis stabilization site for both mental health as well as chemical dependency. I went to the unveiling of CNG's mobile unit, which is just phenomenal, and I went to our own opening of the Thrive Recovery Center in Westbrook, first one in Nassau County. And all of that was great, and I ended the week on a high note, and then I sat there and said, did it really take us all this time to figure out that we need to make services available to young people and their families 24/7? That maybe we should actually go to them instead of requiring them to travel hundreds of miles to get to good care? Why did it take us so long to figure this out? And has it really taken us this long to figure out that addiction in particular needs to be treated along a continuum that includes support for young people in recovery, particularly those that exist in really difficult environments? We've had a lot of discussions lately about vaping, and one of the things we know about young people is there's a certain number of young people who will vape for the first time, who will use alcohol for the first time, who will smoke weed for the first time, and they won't develop significant issues. There's a significant number of kids that will do those things for the first time, not feel high, not get a thrill, but will say, I finally feel normal. And as we try to wrestle that jewel away from that kid, that nicotine it contains, or that joint, or that beer, what we're really wrestling to take away from them is that sense of normalcy. That's why we don't do a very good job at it. The connection between anxiety, depression, and substance use, particularly early onset among kids under the age of 16, is very, very significant. That's the piece that's left undone. And in the treatment world, we tend to chase after the person who's progressed from vaping to alcohol to marijuana to pills out of mom and dad's medicine cabinet, which is where 75% of kids get them, onto heroin and finally to fentanyl. Generally, it's at fentanyl where we begin to intervene and we pull them out of the emergency room and say, hey, just overdose, would you like to get help? Imagine if we went upstream and stopped them from getting into that river in the first place. We're waiting until we're way downstream and doing this, and we're missing critical opportunities. One of the things that I think everyone would agree on is the lack of mental health services on Long Island is astounding. If you try to find an adolescent psychiatrist, if you can find one, you're going to get an appointment that's probably 6 months out. So what happens in that intervening 6 months? We know that mental health conditions tend to accelerate. We know certainly when it comes to addiction, it's a progressive disease and things get worse as we move forward. So I think we've opened our eyes a little bit in terms of ensuring that we should provide services in a different way. I wish there were more integrated services when it came to children's mental health and addiction. We tend to still deal with them, although we talk about co-occurring disorders, we tend to deal with them in very, very separate ways. But there's another thing that we need to talk about, and this is something that makes a lot of treatment providers really, really uncomfortable, and that is the amount of predatory marketing focused on families who are struggling with addiction, focused on families who are struggling with kids with mental health disorders, is astounding. It's criminal. It should stop. And the state has come out and weighed in on this and promised enforcement action. But one of the things we've seen is that treatment marketers representing facilities, and it's not only substance abuse, it relates to mental health issues as well, are coming here from Florida recognizing there's a whole bunch of well-off families that need to do something, anything to save their kids. As providers, we know who the good guys and the bad guys are. We've got to start pulling that out amongst ourselves and making sure that families get the help they need. I've spent long enough ignoring the lady with the sign in the back. So I'll give it back to Rebecca. Thank you.
So now you have 2 to 3 minutes each to answer the next 2 questions, and then we'll open it up to questions from the audience. So the first question that each of you is going to answer, and this one's to start with you actually on this one, is what is one change in policy that New York State, any department,
necessarily think it's a one shoe size fit all. But before, I just want to give, so in Newsday, a special shout out to Toulon. Page 9, you will see that he had a 12-year-old child who's battling with cancer as sheriff of the day yesterday. And that's just to show the work that people are doing. And I know we touch upon mental health, but bullying is a big issue. And legislator presiding officer Dwayne Gregory just created a new bullying task force, a youth bullying task force. And it's led by this kid named Devon Moore. When I met with him, he's 15, I met with him yesterday. And he went to a private school, and he's an African-American boy. They took a Photoshop of him, put a trash can, put a gun to his head with the Photoshop. And if he didn't have a mom that was strong, that understood what she needed to provide for her child, so where would he be, right? Would he be in the statistics of the 5 to 18-year-old black youth? So I say that to say is the one policy is not a one policy. We have to think of culture. We have to think of food security in our schools for these children. We have to think of language, being able to communicate with one, whether they're Haitian-speaking Creole, or they're Spanish-speaking, where there's whatever the language is. As agencies and as a legislator, we have to figure out look at the picture holistically. And I would say funding. Funding is a huge issue, and I think that, yes, you can clap for that. Long Island doesn't get their fair share in services, but that we have to be more vocal about it. One of the things that I've always been fighting for is school health-based centers. Does anyone know what a school health-based center here is? So the state only funds, we only have one on Long Island, which I think is in Hempstead, or in Roosevelt, sorry. And the state does not fund new school health-based centers. They only fund existing. It's sort of like a health clinic in the school district, and what it does, it targets the mental health, it targets the whole health care of the child, and it's not in competition with any outside clinic. Outside clinics actually support the school health-based centers. It provides the providers into the school where the child is looked at holistically, health-wise. So that's one thing that we can fight together as representing this population, our community, our families, our children, is looking at funding to target great programs in our schools, outside of our schools. And I think another thing is being the connector. You know, I remember we had a leadership table, and there were about 30 of us who sat at the table, and many who get to gatherings like this, know each other, say hello, give their kisses, how's your child, how's work doing, but really didn't know the services that each one of them provided. Who, what, where, when, how. We don't really know that, so I think that is important.
So for me, it would be more funding for you, not for me, and I'll tell you why. When an individual leaves our custody, we're faced with, they don't have transportation, they don't have housing, they don't have employment opportunities. So one of the things, especially with this bail reform legislation, where more individuals will be back in their community after committing an offense and being arrested, is the Suffolk County Sheriff's Office is now seeking partnerships, and partnerships so we know what services are available in the town of Babylon, in the town of Riverhead, in the town of Brookhaven. So a formerly incarcerated individual can reach out to us, and this is one of our goals, reach out to us, and we can connect them directly with a name of a person in an agency that we can follow up with. So Errol Toulon's incarcerated, he leaves the Riverhead facility, he needs some sort of housing, he has housing issues. So he reaches out to the sheriff's office using his PIN number so we can track recidivism and know that the person was formerly incarcerated. and then we can connect them to Kimberly Jean-Pierre that works for a housing agency, and now we can make that direct connection and hopefully eliminate some of the red tape and bureaucracy that these men and women face because they're sitting in these spaces waiting for appointments. Maybe they don't have the capacity to actually make an appointment or that confidence to actually move forward and do certain things to reclaim their lives and empower themselves. So that's one of the things is to really, what can we do to help you get funding so that you can help us? Because I prefer to see these young men and women on the streets and in the community than in the jails. So, thank you.
So, clearly funding is a hot topic here. But, I think that, some of the policy things, in our view, sometimes don't make sense. In a sense, so we have a federal law, the Student Succeeds Act, that places a high priority on attendance as a fact. And if kids have low attendance, we could lose hundreds of thousands of dollars in funding. Yet there is a law in the state legislature that is saying that kids who are suffering from mental issues should have excused absences. There's a contradiction. And so those kinds of things, we really need to be on the same page. When I talked about the superintendent survey, another question on that was that how much money do we spend in particular areas? So if in 2017, 52% of superintendents said that was a priority, in 2018, we saw 49% spend more on mental health. Last year we saw, or in 2018 we saw 56%, well we saw 53% spend more on mental health in 2018. So clearly superintendents are investing where they know the problem is. But there's also a situation where we are limited with what we can raise locally under 2% tax cap. So things like, we talked about trying to get exemptions to the tax cap for school safety. Well, I place mental health as a school safety issue. When we developed a 5-point safety plan for school safety, one of those main points was servicing mental health. So clearly, those are scenarios I think that would be beneficial. Thanks.
Thank you. So the one change that I would say is it's time for a paradigm shift for how our elected officials and our leaders think. We need to invert the paradigm. So right now, we live in times of top-down kinds of change. So for example, the district program, right? Billions of dollars to New York State from the federal government, right? And all the rules got set at the federal government level and the state level. Yes, there was input. I was on the MRT task force, the whole deal. And where did the money go? It went to large institutions, right? And that's still where most of the money went. And the rebid for $8 billion is still going to continue that funding because hospitals and large institutions are saying, boy, you can't cut us off now, right? So we need to invert the thinking and say, let's